Hi guys, hi family. This is Dr. T and welcome to Clinical Medicine with Dr. T. So guys, what I want us to talk about today is acute psychosis. Acute psychosis. Guys, just before I start, I know that many people, like many students and many interns, they don't like psychiatry. And I understand. I completely understand. It's not my favorite either. But what is important is that we are students. Some of us are students. We are still interns, young doctors. What is important is wherever we go, as we rotate from one department to another, the important thing is to grab the basics of that department and know the emergencies in that department so that, if something is not an emergency, you can always find someone to help you with that. But when it comes to emergencies, if you are alone, it means that it's just going to become chaotic. Because if you've got an emergency from if you've got an emergency, but you don't know how to manage that emergency and you are the only person that can do something about it. Let's say you're on call, you are alone, no senior around you, and it happens that you are seeing a patient that you never thought you would see. Let's say you hate psychiatry, you don't care about psychiatry, but now you find yourself working in casualty while you are waiting for your reg post to go where you want, or you decide to become a GP and then now you have to do night calls, or you're at the clinic, or even in your practice they bring a psychotic patient to you. So what I'm trying to say is, it's not possible to love everything. We cannot love all the disciplines that we go through. It's not possible. But what is important is to grab the basics of that department and also to know the emergencies of that, so that you can be safe if it happens that you encounter one of their patients in the future. And you cannot predict the future. You just cannot. Okay. So one of the things, like in psychiatry, there are a few emergencies that we need to know. Like managing a psychotic patient is very important to know. That's an emergency because that person can kill someone. That person can also kill you. That person can destroy property and all of that. That person they can lose their life. So it's an emergency, especially if there is disorganized behavior, because that's where it is. Because you can have a psychotic patient who's just talking and talking and talking, who's got delusions and hallucinations, but they don't have a disorganized behavior. We're going to talk about those things now. So it's important. Also, managing an aggressive patient is very, very important. And also managing panic attacks is very important, because it's so scary to see someone who comes into casualty who's got panic attack. Those people, they look like they will die now. They're short of breath. They are breathing very heavily. It just becomes a mess. So, and also delirium tremens, withdrawal is very uncomfortable, and you can lose a patient from withdrawal. So those are the things that are important. Any other thing, it doesn't matter if you can't differentiate one personality disorder from another. It doesn't matter if you cannot differentiate schizophrenia from if you're not in psychiatry. It's not important. What is important is you can see a psychotic patient and you work them up accordingly and refer. Those are the basics that we need to know. If I cannot differentiate one anxiety disorder from another, it's not important. One other thing that is very important, it's specifiers. When you are a GP or you're at the clinic, it's important to pick up that, okay, as much as I see MDD here, but there is psychotic features. As much as this patient has got a MDD or major depressive disorder, they also have suicide ideation. So those are important specifiers. As much as this patient has got bipolar mood disorder, but they also have psychotic features. So it's important to pick those things up. So specifiers, dangerous specifiers are important to take note of. Yeah, okay. So, like we always say that psychiatry is not equal to psychosis, right? There are so many other conditions in psychiatry that are not related to psychosis. And we said that there are four symptom domains under psychosis. And the first one, delusions. Number two, hallucinations. Number three, disorganized speech. Number four, disorganized behavior plus catatonia, right? And as we all know that please, if you have not, please guys, please, I want to beg you, please like the content, please subscribe, please guys, I need the channel to grow. Yeah, so delusions, as we know that these are fixed false beliefs that cannot be sort of like leveled or reversed by just reasoning. They are fixed false beliefs, and they are not in line with the patient's, sometimes not even in line with the patient's level of education, spirituality, culture, and all of that. And this is a perceptual disturbance, and we know the types of, we've spoken about the types of delusions, guys. Go and watch the very first video on psychiatry. Say the symptoms of psychosis. I think that's the title of the video. And you know there are different types of delusions: persecutory, grandiose, delusion of reference, and all of that. And then there's hallucinations, which can be are divided into 5, I think. There's sensory, there's auditory, there's auditory hallucination, and then there's visual hallucination, then there's somatic, there's 5 of them, and then there's disorganized speech, and then behavior. You know, when it comes to behavior, disorganized behavior comes in many forms. One that I remember, there are so many of them that I've seen, but one that still stands out for me is, there's this patient that I was taking history from, and this guy, he was having bread. As we were talking, very cooperative, but what he was doing is that he was talking sense when I was talking to him, but because as I was watching him, as I was talking to him, I was watching him. So what he was doing is that he was eating bread, and then this bread that he was eating, there were moments where when he wants to tie his shoelaces, he would put his bread on top of a dustbin and then go and have a bite and tie the shoes, and then go to the other side, take the bread again, bite, and then put it back there, and then tie the other side. And even though his family members were like, no, you can't do that, you can't do that, then he was still, no, I'm gonna do it. He was very adamant that he's gonna continue with that behavior that he was doing. So that's a disorganized behavior. What I'm trying to say is, you don't have to have someone beating up people, breaking windows to say, oh, this is disorganized behavior. Small things. Another small thing that you can pick up, it's someone who's trying to wear his socks on top of his shoes. Someone who's trying to, even like dressing up, if you are trying to dress up, and the way you are dressing up, you are just mixing up your clothes and all of that. You put a jacket, you put a t-shirt on top of the jacket and all that. That's a disorganized behavior. So it comes in different sizes, in different forms, né? And remember, with psychosis, you don't need all of these. There are patients who will have all of these. There are patients who's going to have only one. There are patients who are only going to have 2 or 3. So someone who's got delusions only, that's a sign of psychosis. Someone who's got hallucinations only, that's a sign of psychosis. You don't need all of these to say someone is psychotic, right? So yeah. So now, someone who's got psychosis, when they come into us as GPs or casualty officers, if we can pick it up that they've got psychosis, then we have done well. The next step would be, I'm not talking about someone who's aggressive now. We're gonna talk about aggression on another video. How to approach a patient who's got aggression. So with acute psychosis, you can have someone who come in acutely psychotic and they are already diagnosed with a primary psychiatric illness, right? Let's say I have this patient is known with schizophrenia or is known with schizophreniform, and then now they come in with acute symptoms of psychosis. They already have no, sorry guys, primary psychotic disorder. That's what I wanted to write here. Primary psychotic disorder. So what I'm saying is, a patient can come in with acute psychosis and they have an underlying primary psychotic disorder, like let's say they have got schizophrenia, right? They've got schizophrenia and the spectrum. You know when you say the spectrum, right? So the conditions there, it's schizophrenia, schizophreniform, schizoaffective, brief psychotic disorder. So those are the conditions that are there. So this patient can come in with acute psychosis and then they've got a primary psychotic disorder. Or they can come in with acute psychosis and they've got another psychiatric, a primary psychiatric condition, right? And which one are those? Like, you can have a patient who's got MDD, major depressive disorder, with psychotic features. Or you can have someone who's got bipolar mood disorder with psychotic features, right? I want to explain this, guys, to you again. I'm saying you can have a patient who's got psychosis, acute psychosis. They come in with acute psychosis. When you flip their card, you find that, oh, this person has got schizophrenia, but now they're coming in with acute psychosis. It could be that they've either taken a drug, or there's a medication that they took, or they've defaulted medication, but they still have got an underlying condition, which is a psychotic disorder. Or you can have someone who comes in with acute psychosis, but they don't have a psychotic disorder, but they just have, maybe they're known with MDD, but their MDD has got a specifier of psychosis, or they've got bipolar mood disorder with a specifier of psychosis, right? Or you can have this person come in with acute psychosis that is secondary to a non-psychiatric condition, which is let's say it's a substance, medication, or another medical condition, right? Let me rewrite this thing nicely. For you guys. So I'm saying acute psychosis, they have a primary psychotic disorder, right? And we said it could be schizophrenia, plus the spectrum, or it could be that they just have a primary psychiatric disorder. Yes, guys, you know, when you write like this, it becomes so simple to have differentials. Even when they ask you on a test, what are the differentials of someone who comes in with delusions? That would be very nice. That would be a very nice question, because you would say, okay, maybe they give you a scenario, say that this patient was picked up by police, roaming around, talking to himself, not wearing shoes or wearing one sock. What are your differentials? Then you would know that, okay, this patient has got psychotic features. So let me look under psychosis. Okay, you can say, you can put for differentials. Oh my God. You know, this is one thing that I used to do in Pretoria University, and I struggled with it, guys. It's only later that I got to understand it. You know what they would say? I remember there was a question. They would give us a scenario. Let's say they give you a scenario of a patient who's got one of these symptoms, and then they say, what are the differential diagnoses? And under your differential diagnosis, you must not tell us about a psychotic disorder. What are the differential diagnoses of this patient? And don't mention psychotic disorder. And you are like, but this is psychosis, so why are they saying I must not mention psychotic disorder? What they wanted us to say is, to appreciate, is that you can have psychosis secondary to a psychiatric illness, which is not necessarily a psychotic disorder. So it means I could have written bipolar, MDD with psychotic features, bipolar with psychotic features, substance-related psychosis, medication-related psychosis, medical condition, psychosis secondary to another medical condition. So I could have written those and not even think about this. But if they give you 10 marks, they say give us differentials of a psychotic patient, then you would put all of those conditions there. Like we said, schizophrenia from brief psychotic disorder, schizoaffective. So you put all those conditions there, and then you come in and mention these ones. So they like they really like to ask like that. So if someone is psychotic, but they don't have a psychotic disorder, but they've got psychotic features, another differential would be someone who's got bipolar, mood disorder with psychotic features, which is a specifier. Or you can say it can be someone who's got MDD with psychotic features. I hope this makes sense. Okay, don't forget to like, guys, please. As long as you have watched, please like. Okay, so now, so this is someone who's got psychotic features, but they've got an underlying primary psychotic disorder, or they've got a primary psychiatric disorder, which can be one of these. And then now when you come to this side, here you're gonna talk about a lot of, it's very broad here. there are so many things, there are so many medical conditions that can render a patient psychotic. That's why we're going to talk about the blood test that you do for these patients. But it's things like your infections, especially CNS infections, brain injuries, electrolyte imbalances, things like that. And we also have got medications, a lot of medications, and then substances. When it comes to substances, like the most common one is cannabis. Cannabis is a very big thing, guys, yo. And then there's what they call methamphetamine, methadone, and it depends where you are. Depends where you are. The list is just endless. The list is endless. It depends the availability where you are. There's nyaope, there's tick, there's tooth, all these things. Mainly the medication. So guys, let's meet on part 2 of this, right? Thank you for watching.